YouTube. We start now the staff meeting of the Compagnons Hépato-Biliares, discussing the clinical case. And the first case will be presented by Jean-Robert Del Perro, and the chairman is René Adam.
Okay, so we speak in English?
Yeah.
Yes, we speak in English now, yes.
Okay, absolutely. Okay.
Marcelo, I don't understand because when I click Présenter maintenant, it show me it's impossible to see the screen.
So you have tried again?
But I try again, yes.
Yes,
But no.
okay. So in waiting that you can be connected, I would propose to change the order of presentation if you don't succeed.
Il faut, Pierre Clavian, il est en train de présenter. Il faut sortir, monsieur Clavian. Il faut
Moi,
sortir.
je voulais rien présenter, mais j'ai juste essayé quand j'ai vu.
Ah oui.
Maintenant, je suis sorti, là, non?
Oui, je vous avais déjà sorti.
Je voulais juste vérifier ce qui se passait avec Jean-Robert.
Alors,
c'est la seule chose en Suisse.
Je fais une nouvelle tentative. Oh, c'est pas vrai.
Il faut suivre les pas. Le premier, c'est présenter maintenant.
C'est ce que je fais.
Choisir plein écran.
L'intégralité de l'écran.
Oui, c'est ça.
Et il me met une erreur s'est produite lors du partage d'écran.
Ah oui, alors il y a des problèmes.
Il faut infiltrer ton ordinateur.
Il faut sortir et entrer de nouveau. On pourrait changer
Oui. Déconnecte-toi et reconnecte-toi. Et peut-être qu'on peut donner la parole à une autre observation. Comme ça te donne le temps de te reconnecter, etc.
Hugo, tu demandes à Hugo.
Oui.
Hugo Marques.
Donc, yes.
To present the case, please.
Okay, very well. So I've got two presentations. One of them is to discuss robotics in liver surgery, as we spoke with Professor Bismuth. And this is a case that was operated yesterday. So even the video is not perfectly edited, but it can be used as an example for this. I think Inês Barros, our resident, is here to start the presentation.
Yes, hello, good afternoon.
Okay,
good afternoon.
Go ahead.
I will try to share my screen. Can you see my screen?
Yes.
Yes. Okay, so we present a case of a 76-year-old man with a medical history of hypertension and dyslipidemia. This is his medication. In January, he did a routine ultrasound and afterwards a CT scan without contrast that showed hypodense lesion with 4 centimeters in segment 4. Later, he did an MRI, which we can see here. In the left, we have the arterial phase. And we can see a non-cirrhotic liver with one solid nodule in segment 4 with 5 per 5 centimeters. Here we have the venous phase. And here we have the T2 phase, where we can see a nodule-in-nodule imaging pattern with an hyperintensive nodule with 1.8 centimeters. In terms of lab work, he has mild elevated gamma GT and a high alpha fetoprotein, 6567, and the serologies and other tumor markers were negative. So the question we would like to ask you is, what would you do to this patient?
First of all, about the diagnosis. No? Is the diagnosis of HCC the sure diagnosis? I think
Yes,
so, but...
The MRI is suggestive, yes.
Okay. Okay, and so you ask about what type of treatment?
Yes.
So, in fact, we have two questions here. First of all, there is apparently no cirrhosis. We know that if it's an HCC, some of them might arise in the setting of insulin resistant with hyperlipidemia, diabetes, etc. This could be the case, but in fact, we don't have a sure diagnosis of HCC. What would you recommend?
So, is there any comment from any other question from the other compagnon?
With alpha factor of 6,000, please. Nodule, alpha factor of 6,000, please.
We agree, Eduardo. The point is it HCC developed on normal liver, on cirrhotic livers? It could be of some importance. I would say, is there any other sign of portal hypertension, of any hepatopathy? I mean, splenomegaly, I have not seen so well. The platelets, the prothrombin time, and so on. All this is okay?
Yes.
Okay, and so your idea was that it was not a cirrhotic patient or?
Non-cirrhotic patient.
Non-cirrhotic patient.
Yeah.
We were not sure. We were not sure.
Okay. Oscar, you want to ask a
yes,
question?
Yes, it's a very interesting case. As far as I know, nodule is most frequently observed in cirrhotic patients with some regenerative nodules, and after some dysplasia process, you can find another nodule of HCC on another regenerative nodule. But in a normal liver, it's very strange to find that. It's clearly for the alpha fetoprotein and dyslipidemia. Is clearly an HCC, but it's very rare to find nodule in a non-cirrhotic patient. What is your position about this?
You may respond, Ines.
Yes. So, can I continue the presentation?
We were discussing whether...
Just before, have you done any, I would say, fibro scan of the left liver to assess, no. I would say, the consistency, the stiffness of the liver? Anyway, my point is, we are almost sure it is HCC. I mean, the fact to assess a cirrhotic patient or not depends if the procedure will change according to the fact that it is normal or a cirrhotic liver. And so, in my view, this will not change much more. But anyway, I let you continue.
No, but let me say something. Yeah. If it is cirrhotic, is a child A, because I have seen the analysis, and is a well compensated. Perhaps if it is cirrhotic liver, is very, as Professor Bismuth said, is a mole, cirrhotic mole, cirrhotic.
Yes,
soft liver,
soft cirrhosis.
Yes. Okay, that doesn't matter. It needs to be operated. Can be operated. If it's a little surprise and he go to operate, it's cirrhotic child A. It doesn't matter. No problem.
Mhm.
May I ask something?
Yes,
Yeah,
Professor
yeah,
Bismuth.
you know, I think one point of discussion is the quality of the parenchyma, and I agree with Eduardo. It changed nothing if it is a child A or it is a normal liver. But the second point is about the number of nodules. Of course, it is solitary nodule, but it is large. And my question is, it is unique nodule, a solitary nodule. We know that in HCC, more often if it is hepatitis, there is not only for this kind of nodule, which is not small, it could be another one. And I remind you that the attitude was to do a embolization and arterial embolization before surgery in order to be sure there is no small nodule around or sometime a distance. I know that now with the imaging technique improving, we don't need to do that. But I ask the question, do we think today we need to do this kind of embolization only to see the nodule, which was the attitude some years ago? René, anybody may answer. To be sure that the nodule is single nodule, which is important for the attitude.
My opinion, very briefly, I think this was indeed a good attitude in the past, but now with the performance of MRI, I think we don't need anymore to do this when MRI is done. In addition, we can do choline PET-CT or FDG PET-CT, who still increase the accuracy of the diagnosis. And by this way, I think we have now imaging techniques that are sufficient to make a good diagnosis, not only of the tumor, but also of the number of tumor. It's my opinion. Now, any other comment?
Yes, can I speak?
Yes, Laurence.
Hello, everybody.
Hello.
Hello, Laurence.
Hello. Concerning the diagnosis, we have recommendation. I mean, if we are sure it is a cirrhosis, we do not need any biopsy. But if there is no cirrhosis, the recommendations say whatever the alpha fetoprotein is, we have to do a biopsy. That is the first thing. The second thing, I don't agree. It's the existence of the cirrhosis is matters, because if I'm not wrong, this nodule has a very relation with the portal branch, the left portal branch, and the anterior right portal branch, very, very close. So surgery will be an extended hepatectomy for me. So it is important to know before if there is or not a cirrhosis and what we are planning as an operation. So, to my opinion, we would have done a biopsy of the normal liver and the nodule, both biopsy, before planning any operation. That is the first point. And the second point, I don't know, but if I see the MRI, the operation that would be necessary is an extended left hepatectomy to the right anterior segment, and it's a huge hepatectomy, so we need volumetry, etc. So before everything, we have to know the nature of the liver, to my opinion.
Laurence, let me just tell you about the hepatectomy. We also thought that he needed an extended hepatectomy. Maybe it's not so evident, but there is some small space between the left branch and the tumor. But we did thought that he would need at least a central hepatectomy, 458, at least that, because at least the right anterior branch and part of segment 4 are affected. We would have to compromise with a positive margin in the hilum, because of the location of the tumor that sits over the hilum. But besides that, at least a central hepatectomy.
Yes, Professor Bismuth.
Yes, according to what say Laurence, I come back on the embolization. For embolization has not only the merit to find other nodule, I agree with everybody. Now, improvement of the imaging technique, we don't need for that. But to reduce the size of the nodule, at that time there is an advantage. And we know that the large nodule may, after embolization, decrease in size and change the extent of the liver resection that is needed.
Now, radioembolization is more widely used with the advantage, in addition, of inducing an atrophy of the liver who has been radioembolized. And so I think now we are living a sort of switch from chemoembolization, not for all patients, of course. Chemoembolization is more easy to be performed, but from in difficult case for which the resectability is not so easy, to discuss radioembolization, possibly much better than chemoembolization in a way
so
to size reduction.
I change my question. I say, René, do you advocate in this case radioembolization to do economy of the liver section?
No, I don't think so, because we need to see possibly much more, and possibly we may ask Ines to come back to the case and to show us really what was the contact of the tumor with the vascular structure, and then coming running on the observation.
Can you show Ines?
Yeah, of course.
Then can I make a comment?
Sorry?
It's not this case, I think, yes.
No, this is Marco.
Sorry. So I will show it again.
Mm-hmm. Yes, it comes to the contact of the sectorial anterior branch.
Can I say something?
Yes, Pietro.
Well, two things. One, I think we have an obligation to say, other people are watching us, and to say what's standard guidelines and what can be done. I think that nobody would do a PET choline on this patient, and I think the imaging of MRI is enough to exclude other nodules. That is accepted. The other thing is, there is true enough, as Laurent says, there is a need for a biopsy because it's not a not cirrhotic liver. However, with 6,000 alpha-fetoprotein, I think that can be reasonably put aside. Third thing, these tumors often have a capsule on the saddle of the portal vein, on the hilum. And if you do a central hepatectomy, just half of complete segment 4, and following the Glisonian plane on the hilum, they detach beautifully, most of them. And you don't need to sacrifice the right side of the branches of the anterior sectorial pedicle. So I don't think it's such a huge hepatectomy. If the tumor, and you can see often whether there is a capsule on MRI.
Mm-hmm. Good question.
I would say, for example, in the hilum, you could see that it probably would easily detach. But on the other side, on the left branch, if you see the MRI, in fact, there is some space. In the right anterior pedicle, I think it is deeply involved by the tumor.
Well, you will see that
see.
You can take the whole anterior pedicle, but I don't think you need to do that.
Mm-hmm. Okay, Ines, could you continue?
Yes. So we discussed the case in our multidisciplinary meeting, and we decided to perform a liver biopsy. The liver biopsy of the non-tumor parenchyma showed a liver fibrosis, stage 2, and the liver biopsy of the nodule showed an acinar hepatocellular carcinoma.
Let me just add, Ines, sorry. This is one, because of the reason Laurence explained, the need for a biopsy in a non-cirrhotic liver, but also because we thought that the fact that the liver was cirrhotic could influence the management of the patient immediately, because we could opt for for example, a chemoembolization if we were thinking of a large hepatectomy, as we were. So these were the two reasons why we decided to do the biopsies. Okay, Ines, please.
So now we have the diagnosis, and we would like to ask you again, what would you do now?
So,
I think,
yes.
I think you can show, I don't know if you can show already our option, or if you can discuss more the options, because in fact we did discuss what would we do surgically. So Ines, can you continue to the next one?
So we discussed again in our multidisciplinary team, and we decided to do a robotic mesohepatectomy. And now I believe Dr. Hugo is going to show you the video of the surgery.
Okay. So I'll take the screen.
The liver function was strictly normal. Huh?
Strictly normal.
Yes.
Yes.
The platelet also, the MELD was low.
Normal.
Normal.
Okay. No portal hypertension.
No portal hypertension.
Okay.
We could in fact decide to do this without a biopsy. It's totally debatable, and we would accept this, of course. So this is the setting. Can you see this?
Yes, yes, we see. Put full screen, please. If you.
I think it's full screen.
Okay, good.
So the start of a surgery, basic steps for removal of the round ligaments, exposure of the IVC. This is not totally edited yet because this was done yesterday. The patient is doing well. I've seen it yet today, but so we didn't have a lot of time to edit this, but still I think it's we can show it. So the IVC and the hepatic veins. You see here the preparation for the pedicular clamping. We use normally an external Pringle. That in this case goes perpendicular to the pedicle. We were also thinking about enucleation, simple enucleation, but we did thought that the right anterior pedicle was totally involved by the tumor, as you could see here in the ultrasound. The right hepatic vein is free. We start by dividing the bridge between segments 4B and 3. Partial cholecystectomy that we use for traction. You can see the tumor here, sitting over the hilum. And then we mark a plane of transection. We are in fact leaving a little bit of segment 4, just a little in fact, but we can see there is a margin in the ultrasound. Again, the relation with the pedicle. And we start the hepatectomy without particular clamping first. I think sometimes in the robot we see too well and might look a little bleedy, but usually the blood loss is not very high. This is without clamping.
So, Hugo, you decided to do
central hepatectomy.
4, 5, and 8
yes.
hepatectomy according to the new classification of the New World.
Exactly.
Promoted by Pierre Alain.
Exactly.
Now we should speak the new language, you know?
Yes. So with that Pringle, we were not very satisfied with the operative fields. So we continue. The assistant is using the CUSA. So we arrive at the highland here. This is the middle hepatic vein, close to the origin.
Das Zug-Hin-Gleisbewegen begrüßt Sie im Intercity 1 nach.
So here we are. This is the right anterior pedicle that is being ligated. So after the right anterior pedicle, and so there's a small leak there that we'll repair after. You can see there is a demarcation. We use endocyanine green to select the exact place for the demarcation in the right side. Inferior part, see here. And in the upper part also, we continue the demarcation line and confirm it with the injection of indocyanine green to see the perfect plane. And we continue the later part of the transection, the right side. This is before Pringle. Here you can see the right hepatic vein. We are following the plane. And so I'm going to speed it up a little bit.
Could anyone mute the microphone, please? Because we have a noise. Could anyone mute the microphones? Thank you.
So the final part. And this is the final transection plane. So this is it. So the specimen is removed, and after hemostasis and biliostasis here, you can see again the plane that was transection was the one that we respected, the plane that was marked, and then some fibrin glue and the drain that we usually do in the central hepatectomies. So that's it.
Fantastic. Congratulations for this very beautiful video. So indeed, you can spare part of segment 8, if I understand well.
Yeah, I think we removed all segment 8 here. But
You remove all the segment 8.
All of segment 8.
Okay. So, in view of beginning the discussion, I would say, Hugo and Ines, you are experienced open surgeon, laparoscopic surgeon. Why robotic surgery? I know that, of course, we are a university center and we should develop this and we should explore this. But as experienced surgeon, what are the advantages that you see by using robotic surgery, knowing that presently there is still no evidence-based data showing that robotic surgery do better than laparoscopic or open? So what is your feeling as experienced surgeon?
Well, René, what I think is if you do major hepatectomies such as this one, I'm not speaking about, for example, right hemiapatectomy, but this kind of hepatectomies, I think that the ability to inject indocyanine green, to turn the instruments, to have a wider angle of use of the instruments, the improved magnification helps in doing this type of surgery. I would say for me, and this is not the best example of a central hepatectomy. I think it's maybe not so clean as I like to see it, but still it's from yesterday. I think for me, I would say it's easier to do it this way than by laparoscopy due to this, especially the ability to change the instruments and to position them better.
Mm-hmm. Good. Comment from the other companions, the other attendees?
Yeah, can I make a comment? Do you hear me?
Sure.
Yeah, no, number one, congratulations. I mean, very impressive. And obviously, you are expert in this robotic surgery. We are not so far in Zurich. We did our first Whipple last week with the robot. And I must say, I'm very enthusiastic about going with this machine. I agree with René that we need more data and need some commitment for that. I have just a comment first. I mean, I would have not done biopsy here myself. We are doing now a study taking ITG green, HIDA scan, even the LIMAT test. And from that, if it's perfectly okay, we don't go for biopsy, and the tumor probably not either because of the risk of seeding. But I don't think it's wrong. I think that's a subject of debate. Question for you, video here. I'm very impressed by the lack of bleeding. You have no bleeding. I understand you've done minimal or no Pringle. So how do you achieve this? Do you have a very low central pressure? Do you have a high intra-abdominal pressure? In the few cases, in fact, 2 cases with us, we tried to do that, and I had hair emboli, which I was very worried. And now I learned from other more experienced people that we keep the pressure at 8 or 9. So in this case, what was your intra-abdominal pressure when you did this resection?
Pierre, you are. I totally agree with you. And the problem of air embolism, since we use air seal, there are some air embolisms as long as you have an exposed vein. This is very frequent. So we use 10 to 12 pneumoperitoneum. We have a very restrictive fluid policy of the anesthesiologist. The patient might finish the hepatectomy with 200 milliliters of saline infused. And we are not so liberal about Pringle. We did three 10-minute Pringle in these patients. So we try to use Pringle more here because if not, I think, as you say, it will bleed more.
I think as a teaching point for many people, I mean, I'm an advocate, whatever, for Pringle. I will use it more liberally. Obviously, you succeed that technique and it's beautiful. But I think it's better to have a Pringle 15 minutes the way we do with open surgery, rather than to absolutely force with intra-abdominal pressure high to prevent bleeding and have emboli. Obviously, you are showing the opposite, but I think this is possible only when you have the degree of expertise you have in this. The other questions, I'm not use the vessel sealer and the CUSA, I can see. So the CUSA is a laparoscopic one, since there is today absolutely no machine on the robot to transect the liver, which seems to be pretty appealing. I found the vessel sealer alone, when you started, very dangerous on the liver, with sometimes very significant bleeding. So I have used always the harmonic scalpel. The problem with no angle, a bit difficult with the harmonic scalpel, so we wait better instruments. So in your experience, this approach of the CUSA and the vessel sealer, which is probably quicker, is safe?
Yes, I think we have to use a second experienced assistant, a second surgeon, but it's safe. And it's rather quick. We finished this operation in 4 hours, which I think it's what we would take open, and the blood loss was around 200 milliliters. I think this is a safe approach. I think that they are going to release a new type of instrument. I think it's called SynchroSeal, I think, which is thinner and it's a better vessel sealer and might eliminate the use of CUSA. But I think just the ultracision is not enough for this. I agree with you. You have no amplitude of movements and it's more difficult.
We tried this new instrument and others. I will be very careful. Did you try it?
No, not yet.
The appealing part is that you can undulate it. We're very excited, but it tears the tissue. It's not clear. I think we have to be careful, and we need to evaluate this new one whether it really suits. Because what you achieve here, I'm not sure that any other instrument can do better.
Can I make a comment?
Yeah.
Oh, hi. Hi, everybody. Is an early adopter of robotics, as you all know. First of all, Hugo, congratulations. Magnificent video and great surgery. I don't know, in literally hundreds of these cases, I have to say that there's a little bit of luck in terms of bleeding, and in some livers, you use vessel sealer and you can just go through without any Pringle maneuver, and you can complete essentially the right hepatectomy without making one Pringle, and it happens. And in certain cases, you just make a little start right next to the gallbladder, and you can lose a lot of blood despite the Pringle. And the vessel sealer is reliability, I would say 60 to 70% at best, and in some cases even less. So you have to keep that in consideration. Obviously, help of CUSA is great if you have a very experienced assistant in your institution to help you. So that's sort of a bypass. I think I've spoken to Intuitive more than once about trying to develop the CUSA attachment to the robot, but so far I don't think it's even in the development. So I don't think that they're interested really at the moment. So, but one thing to say to everybody is just it's still a very new field, and despite the fact that a lot of people are trying to do this regularly, I have to say the success is kind of mixed, and especially in areas like this, in central resections, major resections, right hepatectomy. So yes, we have to continue, we have to advance, but I would be very cautious about performing these super major operations, especially if you don't have good assistance or good experience in that.
Okay. Yes, Marcello, yes.
Yeah, I want to congratulate Hugo Max for the nice surgery, but I have one question, and it's about the margin. I was a little bit worried about the margin because when you were dissecting, I could see the tumor, the surface of the tumor, or I'm wrong. I want to see if you cut the tumor and see a good margin, and when you have the possibility to perform the surgery, now open surgery, do you think it's not more safe to perform the surgery by open view than by laparoscopic or minimally invasive surgery?
Well, Marcel, thank you. I think that we compromised about the margins since the beginning because we knew that if the tumor is sitting on the hilum, you would always have a positive margin there. And then we gained a negative margin afterwards. But at that point, the margin was positive, and we knew that. And if we did this open, we would do the same thing. Because if not, if you want a negative margin here, you could have an option of doing a right extended with a bile duct resection eventually. This could be another option. For this type of tumor, that is encapsulated HCC, as Pietro was saying, I think this is a safer option. And I think this is not more dangerous than you are doing, for example, in open, because the ability of suturing is very easy here. So if you have an accident, it's not like laparoscopy where we could, sometimes you have some difficulty with your angle and suturing. With robotics, you can suture very quickly and easily. So I would say this is perfectly safe.
Very good points. Any other comment or question?
Well, just on the safety comment, just a little more. You know, I think the one thing I haven't said is that in the sign in green, showing that Hugo demonstrated so beautifully, you can clearly see your margins. You can really clearly see your outline, and you can also see bioleaks very well, which prevents a lot of problems post-op. Now the visualization is 3D, and no matter what anybody will say comparing to laparoscopy, the view is magnificent, and you can magnify it, you can change the aspect ratio on the monitor and so forth, so you can really see what you're doing. Suturing is just as easy as open, I would say. After a few cases, if you get a hand on this, it's really no problem. So I think actually safety of the robot is tremendous. And I echo the comments of Pierre Clavien in terms of the pressure. Yes, in early cases, I also had a lot of experience with air embolism, and so the pressure has to be kept low. Some people say 10 to 12. I try to keep it under 10, and that's really important. So,
yeah. Anyway, so congratulations to the Lisbon team. Congratulations, Ines, and also all the rest of the team, and Hugo. Yes, Eduardo, yes.
May I say something? Sure. You forget to congratulate me. Why?
Sure,
Why? Because
sure.
It's the last thing I have done in my department before I retired was to buy this robot. I went twice to Pakistan because I wanted to leave to Hugo, and now Hugo is the director. Finally, is the director of the center, is the chairman of the center. I would like to say that I never it was Dimitri who convinced me. That's a good thing to give to the department this robot. And I think that Hugo have done already more than 80 surgeries. I don't know, Hugo, how many?
We are reaching 100 now.
Okay. So, okay, this is just a joke to improve my autoestima. And I am very proud. I knew that not for me, but I wanted to give give the robot, the first robot in Portugal. Is the first robot in the public hospital in Portugal. So
thank you, Eduardo, and
yes,
thank you for letting me use it also.
Thank
for
you.
The first time. Thank you.
Fantastic gift to you.
Yes.
Okay, so I think we should go now to another case. Professor Bismuth, do you nominate another chairman or chairwoman? I don't know what you want.
Yes. Eduardo, if I understand well, you left and you give a robot, and the robot replaced you now with near Hugo. This is good. So, okay. Now we go to another case, and Eduardo, you will be the chairman now.
Fantastic.
So, Eduardo will present Pierre-Alain, and Pierre-Alain will continue with the robot. For I think he has a case of robot also. Pierre, is a case of robot that you have?
No, well, but it would be difficult to load. Maybe next time, not this time.
So not this time. Okay, so
Not this time.
The next case is Hugo, not Hugo, Eduardo, not Hugo, but Laurence. Laurence, where is Laurence? She left. No.
No, I'm here.
You
I'm
are
here.
Okay, may you present your case?
It's not robotic. You
No,
will
I
be
know.
disappointed.
Eduardo.
Yeah. Okay.
Please. Eduardo, please call Laurence now.
Yes, Laurence, it's a pleasure to see you. Okay, it's not robotic, but I'm sure that will be a nice case. Could you present, dear Laurence?
You have to choose. I have a simple one and I have another more technical. What do you prefer?
I would prefer not the technical.
Technical?
No, not technical. Technical.
Not technical?
Yes.
Okay.
Show us both, Laurence. Start with the more difficult one and then the easier one, if you don't mind, of course.
Do you see my slide?
Yes, we see very well.
It's a simple and very short case. It's about a woman, 34-year-old, admitted in emergency for abdominal pain and anemia. The hemodynamic was stable, and she experienced a pelvic major pain with abdominal tenderness at examination. Her hemoglobin was 10 gram, and on CT scan, there was moderate hemoperitoneum and hepatic tumor in the right liver. And because it's the patient, she was, of course, COVID plus. And she was transferred in my department to discuss embolization. This is the CT scan. As you see, the tumor in the right liver, segment 6, the hemoperitoneum, which is not so important, but in the pelvis also. This is, okay, she had no previous history, no medication except the estroprogestative pill. She was stable, bleeding stopped. So what is your diagnosis and what is your management?
Yes. There's a young lady with this taking the pill. Okay, there are only 2 tumors that could bleed like that. Was the adenoma or the hepatocellular carcinoma? But for the moment, I think that's important to do the arteriographic approach before the right diagnosis. And anybody would comment?
Eduardo, I'm just make a quick comment. I think, she was unstable when she was admitted. And also there's a question of being COVID positive and the risk to staff, the treatment. So our approach for this would be an embolization now and possibly surgery later.
Yeah.
I would advise embolization.
Yes,
probably an adenoma, rupture adenoma with a hemoperitoneum.
Okay. So in emergency, I decided exactly like you, considering that we wanted to discharge the patient rapidly. She was completely stable, I repeat, but we decided to embolize the patient. And this is the embolization, as you see on the left. This is the arteriography. And as you see, we embolize the posterior branch of the artery. Okay?
Well.
However, the diagnosis was quite disturbing because on CT scan and arteriography, radiologist was in favor of an angioma and not an adenoma. By the way, the radiologist also noticed the existence, I didn't of an ovarian mass that should be investigated later. So we discharged the patient and we scheduled an hepatic MRI to confirm the diagnosis of this hepatic tumor and also, of course, a gynecologic investigation with a pelvic MRI. And I saw the patient in consultation to decide or not hepatic surgery for this exceptional bleeding angioma. And this is the MRI of the liver. Did you see it?
Yes, we see.
This is the T2 sequence. And if you are interested in the pelvis, this is the image here on the right of the ovaries. So, I discussed with the patient at the consultation. She mentioned chronic pelvic pain and explained that all began with an intensive pelvic pain the day before the admission. We thought it was the hemoperitonum, which was, well, very moderate. So I asked the radiologist the conclusion of the investigation, and he said, it is an hepatic angioma. And by the way, concerning the ovaries, they were endometrioma. In fact, she bled from endometriosis. She bled from the right ovary and not the liver. So my messages are rules, angioma do not continuously bleed. Obvious diagnosis is not always right diagnosis. And we have to focus on the liver, but we have to have a glance elsewhere. That's it.
Yeah, fantastic case, but I don't agree that the angiomas don't bleed spontaneously. We have a couple of cases, and one of them I operated myself a long time ago, and I was obliged to do a liver transplant, a urgent liver transplant after
packing.
Packing that in another hospital, and was a spontaneous bleeding. So, okay, I agree that she's 99% perhaps or something like that. Never say never.
I know, Eduardo, you're right. Never say never. But it's so exceptional without any trauma. Yes. So it was a funny case, to my opinion.
Yes. This is fantastic case because nobody in the room say that was not the. I must confess that I didn't saw the bleeding of the liver, but okay, I thought that was only because it was a small bleeding, you know. But anybody wants to comment this?
Yes, but Laurence, you listen to me? Laurence, you
yes.
Listen to me? Yeah, you said that the day before she had the pelvic pain.
Yes.
Why you did not take attention of that?
Because she didn't say it. In fact, we were focused on the bleeding and the hepatic tumor, and she said she had a pelvic pain, but we thought it was the hemoperitonum in the pelvis. Yes. So
Mondor sign.
Yes. So we were wrong, and we didn't discuss enough with the patient. One message is that really to interrogate the patient, to have a real discussion about the history before having a diagnosis, which was quite obvious at the first glance.
You remember, I often said, even to you, never have only one diagnosis.
Yes, that's right. And when I saw that it was an angioma, I was seeking for another, in fact, diagnosis.
Laurence, I have a question, if I may, Eduardo.
Yes.
You told that the patient was COVID positive. Was she symptomatic? My question arose from the situation that probably if she wasn't COVID positive, you would rather operate on her and not maybe starting with embolization, but rather direction of the treatment will be to the resection. Am I right?
No, I don't think I would have operated her because the bleeding had stopped and she was stable. And I think that embolization can make us wait and schedule the operation later and more safely.
Sure, so, of course.
So I wouldn't have operated her. The point is that I didn't want her to be hospitalized in my department too long because she was COVID plus. And
I see. So
maybe I wouldn't have done an embolization, but only follow-up because it was probably not useful. As you see in the CT scan, there was not rupture of the tumor. There was a hemoperitonome, but not blush on the CT scan. So embolization was not completely obligatory.
Yes. In this case, I agree with you because you underline that due to COVID positive result, you postponed the possible operation. But of course, I absolutely agree with you with this strategy. Thank you.
Okay. Lawrence, perhaps you have time to do the other case. Could you?
Okay.
If Professor Bismuth, you agree that you have the...
Yes. Jean-Robert, are you ready? Jean-Robert?
Yes, I think so.
Are you ready after this case to present yours? Jean-Robert?
Okay, yes.
Okay, so after Laurence. Laurence?
Okay. Can you see my slides?
Yes.
Okay. This is another woman, but older, 63-year-old. She consulted for abdominal pain and a certain degree of discomfort. And on clinical evaluation, there was an obvious huge abdominal mass, and the CT scan can show it. This is the CT scan. This is the arterial phase. This is the portal phase. And she said to me that she had a previous CT scan several years ago mentioning a liver mass diagnosed as a focal nodular hyperplasia, and she broke this CT scan. And the date of this CT scan is 2017. I mean, 3 years ago. Today, this is the point. It's painful. She had alpha-fetoprine 81,000. The chest showed no metastasis, but as you saw, this huge mass liver and caval thrombosis. I don't know if you noticed it. This is the coronal view. As you see, this is the venal vein, and this is the thrombus here descending on the iliac veins. So the diagnosis is a huge hepatocellular carcinoma with a possible one nodule in the left lobe and a thrombosis of the vena cava up to the renal veins. So what do you propose? Surgery? No surgery? What approach? What about the vena cava?
Laurence, even though this could be even resectable, although very, very large, did you consider having a first approach with systemic therapy, considering that we have now rather effective drugs like nivolumab or the combination of atezo with bevacizumab. Some of the patients have excellent responses also.
I considered it was resectable. And I discussed with my oncologist and thought that it was too big to be responding to this immunotherapy.
And Laurence, what about the chemoembolization? You know, we have case of regression of the thrombus, not total regression by the embolization.
I don't think if you saw it, there was a tumoral thrombus in the right vein, portal vein, but in the vena cava, it was crural. It was not a tumoral thrombus. It was just a thrombus of a
How do you know? How do you know it was not a tumoral thrombus in the vena cava?
Because it was not enhancing and not.
Okay.
Well, it was not exactly from the liver, but we have 3 or 4 centimeters of vena cava, which was free, and then the thrombus became lower. And the second point about embolization, it was contraindicated because the portal vein on the right side was completely obtured. So it was not possible to do embolization.
And Laurence, what would you think about radioembolization? Because the thrombus, even of the portal vein, is not an absolute contraindication to radioembolization. And sometimes we see a significant downsizing, and because it's sure that we can resect, but it's a huge operation. I'm sure you have envisaged also this possibility. What is your comment?
Again, the patient couldn't sit because she was really painful, and radioembolization was possible, of course, but I don't think it would have induced such a lowering of size. And you know, as me, that for diminishing the volume, you have to wait 3 months. It demands a lot of time to reduce with radioembolization. Minimum 2 or 3 months.
Okay, more comments?
Rashad, I think.
Well, and I have a comment maybe too.
Please.
Rashad or me?
I don't see Rashad, but okay, Rashad, please. One of you, no problem. One and after another.
For me, this tumor is resectable. You barely take out any non-tumoral liver. It's just a difficult operation that you have to think and prepare. And the risk is that the thrombus dislodges while you decompress the vena cava with a massive pulmonary embolus. So you have to find a way to avoid that and take out the thrombus at the same time. But we resected a very similar tumor with Gilles a few years ago. And if you make a big enough incision, then the operation was not too difficult. I haven't seen all the technicalities of the operation, of course, but I think I would go for surgery up front to deal with the vena cava thrombus. I would prepare for a bypass.
Yeah, a bypass. But what bypass?
From an axillofemoral.
What femoral?
So that you can clamp. Huh?
What
I haven't seen. I mean, Laurence, you have. I mean, I haven't seen. I've seen this scan in 3 seconds going in front of me. So I would need a little bit more to something intelligent. But I would dethrombose the caver would put a filter at, no, I mean, let me see the CT scan, let me think about it.
You are always saying things intelligent, Pietro. And
Just,
you're right.
But this is an exception, yes.
Just
You're
another
right,
comment.
but I can tell you that the vena cava was thrombosed, and the iliac, the left and the right iliac vein had thrombosis too. So bypass was, well, difficult, you know. So I agree.
But then just clamping it, because if she's got collateral, I mean, what was amazing in our patient is that she had huge collaterals of caval compression. When we opened the abdomen, everything resolved. So in this case, I don't know whether it would resolve.
Let me just say also, we have a similar case, a very recent one, with the thrombus extending to the femoral veins. We did not hope to extract the thrombus. I think it was totally thrombosed. So we decided not to use bypass and just to ligate the vein, assuming that there would be collateralization. So you would probably tolerate this without a bypass, I think.
I agree. I have a similar experience, and ligating the cava doesn't result in any problems. Just like Pietro said, the collaterals probably by now are so massive that there will be no hemodynamic changes.
The point is where to ligate, because the thrombus involve the renal veins. That's the point. In fact,
you can do one thing. You can ligate after that, and you can do, for example, a graft or a reconstruction to drain the renal veins upwards to the liver, to reconstruct the IVC.
And reimplant
the two renal veins.
Yes, but it's quite a dangerous procedure about the renal function, of course. So my concern was exactly what said Pietro. I think it was resectable and with a big incision, of course. And but the problem of the compression of this huge tumor would be dangerous. So
somebody has a microphone. Can you turn the microphone off, please?
Yes. Could you, Rashad, do you want to comment before Lawrence continues? Welcome, okay. Rashad. You have no microphone. You have no microphone, Rashad. Rashad, please put your microphone on. No.
Laurence?
I continue? Again?
May I ask a question?
Oh, Jean-Robert, yes.
Yes, just a question. It's a problem for the right kidney, but on the left side, it seems that the genital vein and the surrenal vein are obviously fluent.
Of course. You're right.
There is no problem for the left kidney. And probably you can take into account the fact that the renal function, despite the thrombosis in the right side, is okay. The renal function of the patient is okay because the left kidney is perfectly vascularized.
Yes, you're perfectly right. The left kidney is always good because of the collaterals, and this is not the case of the right one. And the point is that the vena cava was completely obstructed by the huge tumor. So, of course, the renal function was good, and as you saw on the CT scan, the two kidneys were functional. Okay? So the point, I thought that it was possible to remove or to abandon the right kidney, or to try to reimplant the right renal vein. That was an option, and well, it was an option. So what approach you, my companion, would advise?
Rashad, you have to.
Yes. Can you hear me now, please?
Yes.
Can you hear me? Would you consider chemolipidol, Laurence? I mean, chemoembolization is contraindicated before the right portal vein thrombosis and the huge tumor that run the risk of tumor lysis syndrome. But in order to reduce the mass, would you consider chemolipidol only?
Rashad, I never saw that chemolipidol can reduce sufficiently this huge tumor. So I didn't think it was an option.
Yeah, okay. Thank you.
In fact, I would say I just go on. So in fact, I did the surgery and I used thoracofrenolaparotomy. As Pietro said, believe me, with this incision, it's not so difficult because you have the possibility of taking the tumor in your hands, and you can easily control the superior cava up to the liver. I used only a total vascular exclusion of 30 minutes, and I did a iliac approach to put a balloon catheter into the vena cava to prevent embolism and to clamp it before removing the tumor. I did also a vena desobstruction that I think really it was complete. It was a 4 hours procedure with 1 liter bleeding, and she experienced a good recovery with this thoracofrenolaparotomy, and she had only 1 day in intensive care unit. But this is the CT scan. The post-operative, as you see, she has a pleural effusion. This is the left liver. And as you see here, the vena cava was free there, but it remained thrombosis in the right iliac vein, and she is in anticoagulation. She was discharged yesterday very well, and the alpha-fetoprotein dropped to 119 at the end of the hospitalization, and she is scheduled for a post-operative immunotherapy protocol. So what I want to do, the message I want is some HCC on normal liver has a very, very low growing curse, and thoracofrenolaparotomy is an excellent approach for these huge right tumors. And maybe, as exactly as you said, I should have ligate the vena cava under the renal vein, because I was able to free the renal vein. But I thought my thrombectomy was complete, but it was not really, and she had to remain on anticoagulation.
Thank you.
Okay. Is it still at risk of thromboembolism? Because you still have a clot in major iliac veins, and you don't have a filter in there, so she probably is still at potential risk for pulmonary embolism, right?
But I can tell you that when I did perform the thrombectomy, the first clot was completely free, and the second one was a fibrous. I had to express the vena cava to take off this clot, which was not free in the vena cava. So I hope that what remain is a fibrous clot, and the probability that it can migrate is probably low, and I will remain her on anticoagulation for that. Maybe I should have ligate the vein. That's why.
Professor Bismuth, please.
Yes, no, thank you, Laurence. It's a very demonstrative case. I only come back on the first message. That means, unfortunately, this patient was considered with a benign tumor for 3 years.
Yeah.
And I think you know that, but I think we have to stress on this message. The diagnosis of benign tumor of the liver is only by default, only after excluding a malignant tumor. I observe so many cases like this one in young people, with intrahepatic cholangiocarcinoma, fibrolamellar tumor, and with slow-growing tumor observed for several years. And it's terrible to observe when the tumor becomes painful and very large. That means that, of course, among us, we know that we must exclude the malignant diagnosis before accepting the diagnosis of benign tumor. But you know that.
Yes, and it's quite frequent to have this diagnosis of focal nodular hyperplasia.
Exactly.
It's very, very frequent.
We have to teach.
I have a question. I have a question for the group. Maybe if I had this case, I would consider doing this operation on full circulatory arrest. And what do you guys think about that?
Full circulatory arrest? Why?
To kill the patient.
No, because you have a fully controlled environment with the cava. You don't have to seriously consider a situation of pulmonary embolism during surgery. You don't have a serious problem with the bleeding control of a case like that. I understand that your incision is magnificent and you have full control, but this is just a thought, and we've done a few cases like this with cardiac teams, and it's such a beautifully controlled environment and such peace of mind that in some instances I probably would consider.
Dimitri, I agree with you when the thrombus is near the heart, but here with the thoracophrenolaparotomy, you have perfectly control of the vena cava up above the liver, and honestly, for this patient, it was safe because I could do the vascular exclusion without any chance of migration of the clot, and that was my my feeling, and that's why I didn't schedule a bypass or cardiac assistant.
No, but this is just I'm not arguing that I would do that at 100%. I'm just making a point for the point of discussion, so we can analyze all the options that are available for an operation of this magnitude. That's all. No, congratulations. You did a fantastic job. It's beautiful.
Laurence?
Yes.
First of all, bravo. I really like your case as usual, and I like the technique that you used. It's just a suggestion now that you've resected the whole tumor. It will be very useful to liaise with your vascular surgeon, not the radiologist. Very few experts do a venous stent with a new generation of drug-eluting stent, and it might worth to discuss with them. And I'm talking about your IVC and the iliac vein thrombosis. So it is just a suggestion for later. Maybe it will be just useful to discuss with them. And it works.
Okay.
Okay. Thank you a lot, Laurence. And we go now to the case of Jean-Robert. Jean-Robert, are you ready?
Yes.
Okay, and the next chairman could be Pierre-Alain. Pierre-Alain Clavien is here.
Yeah, I'm here, but I'm not sure that I can stay until we finish at 4. Is that the plan, or? Because I have to join for something else. But at what time do we finish?
Jean-Robert is presenting a case now. And you are the chairman.
I start. That's okay, I start. Okay.
work. Partager. Est-ce que vous voyez mes... Do you see my slides?
Yes.
Yes, you see? It's okay?
Yes.
So, I show you a short case report with a misdiagnosis and a very debatable strategy. The story begins in October 2013. It's a male patient, 59 years old, with an history of partial nephrectomy for cancer, 1 year, and he was referred to the out-clinic patient in my institution with a diagnosis of pancreatic metastasis without any biopsy. He was a nice, very nice man with a good performance status, but cigars and whiskey consumption, very significant consumption. His BMI was more than 30. I do just a comment on the suspected diagnosis when the patient was referred to my hospital. Of course, everything is possible, but clinically, it's too early for a pancreatic metastasis. These are the CT scan. Upside, you can see the arterial phase. I select only the significant imaging. You see here the pancreas. You see the morphology of the patient on the CT. You see here a small tumor with probably a cystic component. This is a magnification of the view here. And this is the portal phase. Probably here with a hemorrhagic spot intra the tumor. And the conclusion is this is a tumor of the processus ancinatus, probably cystic and solid tumor. This is the diffusion MRI, and you can see here the tumor. This is the PET, and this is the US with the solid and cystic component, and of course, Marc Giovannini performed the FNA with sufficient material. I want to show you the visceral fat area of the patient on this coronal phase. You can see the tumor here. And this is a look of the left pancreas, which is either fatty and atrophic. You can see the splenic artery, the vein here. This is the splenic vein, and the left pancreas is here. FNA, no contribution. Pathology, very difficult, no conclusion. So I think that, no doubt, everybody will say surgery, but are you suggesting a possible diagnosis first, and what operation do you propose?
So Jean-Robert, you just mentioned it's too early for a MET for the renal tumor. Is that correct?
Yes.
Why do you say that?
Because usually the pancreatic metastasis from renal cancer happened very late in the history, sometimes 7, 8, 10 years after the nephrectomy. And for this patient, it was a partial nephrectomy with a very good histology. And I think it's not logic to think that this should be that could be a pancreatic metastasis.
But not excluded. But the picture, it was PET positive, right? It was PET positive.
Yes, it was PET positive.
Lesion, resectable. I don't know. Any comment? Any idea about the diagnosis from the group?
Can I say something?
Yes.
Sure.
It is not really hypervascularized for a metastasis of pancreatic cancer. So it doesn't like it. I said everybody will say surgery. I do not agree because it's a small tumor. The risk of pancreatic surgery in that patient is very, very high because of the pancreas, because of the obesity. And I don't think I will do surgery without any other without trying another biopsy. And a possible diagnosis maybe because there is no dilatation of the pancreatic duct. It is completely asymptomatic. I don't know if it couldn't be a serous cystadenoma of the pancreas, because sometimes it is fibrosis, sometimes it's very disturbing. And I wouldn't do any operation in that patient without be sure that it is something to remove.
And what you do with the positive PET scan? You are not worried? I mean, I think there was the only positive PET lesion in the body, right?
It is a PET. It is a PET, because the PET in this part of the pancreas, I know that there is possibility of PET positive, because in that incineratus processes of the pancreas, we can have false negative. So I would be cautious.
Laurence, I totally agree. I was very anxious of a surgery in such a patient, but MRI is quite worrying, because there is a diffusion around the tumor, and Mark Giovannini said to me, I don't want to do a biopsy because there is a solid component in my EUS. There is a solid component and a cystic and probably partial hemorrhage in the tumor. I think you must operate the patient. This was the discussion of the staff, but I agree with you. I am very anxious to do a.
It could be. Couldn't it be a neuroendocrine tumor?
It's very interesting. It's very, very interesting.
This is my first diagnosis, because it can be with hemorrhage, it can be cystic.
Yes.
And so this is, and if it's that, maybe it's not used. It can be just followed.
Yeah, it's okay. So,
do you have any tumor markers, Jean-Robert? Everything is negative.
Every markers are normal. So if you want, I continue, and I show you my hypothesis. My hypothesis is, it is not a woman, it is not a young woman, but it could be a solid pseudopapillary tumor, because I have operated 2 years before such a patient with the same presentation. And of course, the decision of PD is very risky. And I think that a sparing parenchyma resection should be a better option, with, of course, a frozen section biopsy. I think as Laurence, I think to a neuroendocrine tumor, but finally, my opinion is possibly is a Franz tumor. The problem is that the malignant Franz tumor are observed often in older patients and malpredilection. So I show you just a very beautiful paper published in 2003 in Radiographics that show the characteristic of a solid papillary tumor, and it's quite the same here in T1 weighted MRI. It's quite the same appearance that our patient, as you can see here. Okay. So, what is the alternative to pancreaticoduodenectomy? I think that the resection of prostitution sinatus is feasible with or without third duodenal preservation. As you can see here, this is the basic anatomy of the prostitution sinatus with the pancreaticoduodenal artery and vein arcade here. And this is the view of a patient with a resection of the prostitution sinatus with resection of the third duodenum. So the choice is first a crocectomy like this. This is the post-operative, the post-pancreatic capsula, or a crocectomy, prostitution sinatus resection with reconstruction under the major papilla here, with the reconstruction with a loop Y here on the second part of the duodenum. And I confess to you that in the perioperative setting, I choose a crocectomy. And I think I am wrong, but I think that I am right. The frozen section said to me, the pathology said to me, it could be a solid pseudopapillary tumor. And probably you are right, and bravo, it's the diagnosis, probably the diagnostic. But the definitive pathology show an acinar cell carcinoma with a small positive lymph node in contact under the capsula of the pancreas, in contact of the tumor. Fortunately, the patient had an eventful recovery despite fistula, postoperative fistula grade A. But my question is now, what are we doing?
Are your resection negative? Everything was negative in the tumors, except these lymph nodes.
Except the lymph node, the resection is okay. But the diagnostic is a problem because it's an ACC. So what to do? I come back just a minute on this slide. This is the view of my patient, the coronal view. And you see a reconstruction on the right with the visceral fat area.
On an oncological point of view, you should complete the resection.
Yes.
And the problem is that, well, you have to deal with this pancreas. So from a minimal procedure, you should think to a maximal one.
You are fantastic, Laurence. You are fantastic. When you see the next slides, you are fantastic. It's incredible. Voila.
This will finish with the total pancreatectomy.
Okay. Somebody else would comment about the situation?
I keep silent because you told me the case before.
So, a huge discussion began with the patient. Just for the teaching, for the young that are online, PAN-NETs, and so neuroendocrine tumor, well-differentiated neuroendocrine tumor, as Laurence said before, and solid pseudopapillary neoplasm, which are clinically similar to ACC, are very common misdiagnoses of acinar cell carcinoma. You have to know this. So, with this final diagnosis, a long discussion with the patient, and with the patient, I decide to postpone the resection because, like Laurence, I think I cannot do a child, a classic child, and probably a total pancreatectomy. So my first decision after discussion with the oncologist was it's totally empiric, but we said chemo, 4 cycles of FOLFIRINOX, but non-stop follow-up for the patient every 4 months. Just recent literature about the intracapsular positive lymph node on pancreatic cancer, whatever the histology. Direct invasion of peripancreatic lymph nodes does not impact survival in patients with pancreatic cancer. 2 papers in 2021 published last month in Hepatobiliary Pancreatic Science and Pancreatology. The 2 papers had the same conclusion: direct invasion under the pancreatic capsula had no effect on survival in patients undergoing pancreatic resection. So this is for the argumentation of my decision. And after the 4 cycles of FOLFIRINOX, nothing happened. I see the patient every 4 months during 7 years. During 7 years, without any event. And this is the MRI at 6 years. So you can see the fatty pancreas here, the common bile duct, the main pancreatic duct, and this is the resection zone. You can see here very well. 7 years of follow-up, the patient is very well, and apart of diabetes, the biology is strictly normal, but on the CT scan appears this image here, outside of the resection zone. And this is the MRI with diffusion, objectiving a local recurrence 7 years after the first procedure. And now,
well, any comment? Not easy. Either you do a local treatment like radiation therapy. I don't know if you want to go back. If the patient now is, 67, you're obviously in good condition. Or you really evaluate the X-ray, which I cannot look at here completely with the vessel, and you go back and you do a resection. I'm not aware of any data that may tell us where to go here. So this is the case. I think the patient and the surgeon were we're lucky. The surgeon was very bright, no doubt. The decision was very good, but somewhat everybody's lucky. 6 years so that ahead. I don't know. I think this is clearly a case to discuss in multidisciplinary team.
Yes.
I don't think many people has experience, and the danger a bit at the end in any MDT is the one was the most influence may win and they may follow that treatment. I don't know. I mean, I think you need to be really look at very carefully if the surgeon or whoever want to go back. I think many probably will just go for a local treatment. I don't know. Any other ideas here, since this is really an opinion case? I'm sure Gina want to say something. I cannot believe she doesn't say something here, Gina.
No, I totally agree from the beginning to the end. I mean, my first thought initially, it was maybe a neuroendocrine. That was my initial thought. So at that time, it was either I follow or either I will do a small resection. The second step is that once you have the histology, it's true, you go for total pancreatectomy. I don't see any other type of surgery. But now, as you said, he gained 7 years. I mean, that's not bad at all. So it's a discussion that you have to have with your patient and also with the MDT, if you want to be curative or if you want to do a simple local treatment. It's a debate. I don't have a clear option, really.
Just a comment. Yes, just a comment. This patient has unquestionably a very favorable biology. This is the first point, because we gain 7 years without disease. She has diabetes, and so we know that after total pancreatectomy, the diabetes is much more difficult to equilibrate. But in my view, we should give the chance to this patient to have a total pancreatectomy.
Okay, other opinion?
Okay, any other opinion, or I continue if you want?
Could I just give a quick opinion? I agree this is a very slow-growing, good biology tumor and still a high risk for operation. So I would err on the side of more conservative rather than an operation. There are other modalities, even SABR therapy, stereotactic radiotherapy for slow-growing, small recurrence might be an option.
So, Laurence, you did everything right until now. You want to give your opinion?
Well, first of all, I just want to ask Jean-Robert, because what I know about a sinner cell carcinoma usually are big tumor, and I didn't know it could be a small tumor like that. So it's very interesting. To comment on the situation now, I think that a local treatment is not for me the best, because we don't know if there is any lymph node. We saw a recurrence, but probably it's a more aggressive recurrence than the initial tumor. So I would do the total pancreatectomy, probably. Or I will discuss that with him, of course.
Scan at this stage, Lavi. The question is, will you do a PET scan at this stage to stage the disease?
I don't hear you. I'm sorry, I don't understand.
So, will you do a PET CT scan, PET scan, whole body PET scan to stage the disease before planning the treatment?
We do all examinations, and there is only a local recurrence.
Okay.
So I discussed a lot with the patient and with my fellow Olivier Turini, because now I'm not on the operative room. So we discussed a lot, and but I know very well the patient, because during 7 years I see him every 4 months. So I know very well the patient. So I continue if you want.
Yes, please.
The patient is reoperated in September recently. It was already diabetic, as you know. Due to the structure of the left pancreas, PD was immediately converted to total pancreatectomy, as said Laurence. Pathology show an acinar cell carcinoma PT1N0. The lymphadenectomy is negative. Fortunately, the postoperative course was uneventful with long-acting insulin and modern pancreatic enzyme preparation. Now the patient is well. We see him 15 days ago. This is the operative field. We preserved the spleen and the vessels. Okay, you can see the preservation of the vessels here and the total pancreatectomy. This is the left pancreas. As you can see, Laurence is right from the beginning. This is a non-alcoholic fatty pancreas disease, typical, and it's impossible to do an anastomosis. I want to conclude with 2 papers, very recent papers in press in Annals of Surgery. Converted total pancreatectomy in high-risk patients with a PD. Pro, already diabetic, atrophy of the left pancreas, BMI more than 30, operative consistency, gastric congestion. This is a paper in Press on Annals of Surgery from the group of Heidelberg, with a rate, I think, was, for me, the rate of the gastric venous congestion was lower than they said in the paper. They said the risk is 15%. Hypoglycemia risk, of course, and the worse quality of life. And finally, it was a misdiagnosis, a very difficult decision, but 7 years of normal life, it seems to be very important. The duration of the follow-up is a major concern. I don't stop at 5 years. And 2 papers, I think this paper in Press in Annals from the Verona group is very interesting because, as you can see, it's very interesting. More than 700 patients, 86 patients in this cohort were converted total pancreatectomy from a planned pancreaticoduodenectomy. And if you look to the results, less hemorrhage, less clavien, more than 3 complications, a short median hospital stay, but a worse diabetes-specific quality of life. So je vous conseille de lire, to read this fantastic paper from the Johns Hopkins about acinar cell carcinoma, because it's very, very, very interesting. And I show you some highlights. Acinar cell carcinoma is rare, with distinct inherent biologic behavior and clinicopathological characteristics. We have to recognize the histologic and cytomorphologic features. Surgery remains the treatment of choice when there is no metastasis, of course. And what is in the recent literature has shown very promising results with chemotherapeutic agents used in the treatment of colorectal cancers, because the genetic of acinar cell carcinoma is similar to the genetic of colorectal cancer. Thank you.
Yeah, Jean-Robert, thank you. This is absolutely superb case, really an example also with the literature, something is rare. So I think this is exactly what we like to have here. I don't know if there's any other comment. Not many have huge experience with this tumor, usually diagnosed on the pathology. When it comes back, we don't detect that. But I think there's a very nice take-home message. I don't know if someone here has experience or would like to challenge some of the comments from Jean-Robert. If it's not the case, then I give the word back to Professor Bismuth.
Okay, thank you, Jean-Robert. Thank you, Pierre, and all the others for this discussion. Jean-Robert, this is a magnificent case, really, and difficult for the diagnosis, difficult for the strategy, and also difficult for the technique of the resection. So it's a very nice case. Thank you. Now we may have a very short case to finish. Hugo, you have to present the case. You may do it shortly.
I think so. It's not a very...
And why not to take Gina as the chairwoman? You did not speak a lot today, so
sometimes I like to listen. I learn a lot.
Okay,
so Hugo, go on. And Gina also very short.
Okay.
Very short. Go on.
So I ask Ines to present the second case.
Yes. I think I cannot share because Dr. John Roberto is sharing his screen.
Alors, comment je fais là? J'enlève ça.
Arrêtez la présentation.
Arrêtez. Ouais, arrêtez la présentation.
Vous êtes en train de présenter. Oui, je veux bien arrêter. Comment je fais pour arrêter? Je suis nul avec cette... Comment je fais pour arrêter? Je suis perdu. Alors, levez la main. Non, je ne lève pas la main. Tac. Quitter l'appel. Arrêtez le partage. J'ai trouvé. Voilà.
Super. Inès.
Can you see?
Yes.
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 Okay, so now we present a case of a young 36-year-old woman with no significant past medical history besides taking oral contraceptives for more than 20 years, which she stopped taking 3 months ago. She did a routine ultrasound that showed multiple heterogeneous nodules, the largest having 6 centimeters in the right lobe, and a mild intrahepatic bile duct dilatation. Afterwards, she did an MRI in December last year, which we can see here. As we can see, there are multiple focal lesions in the right and left liver. The largest heterogeneous and hypervascular lesion in segment 6, having 6 centimeters. Here we have the T2 phase. We can also see a small cyst in the right liver. And here we have the MRI after the injection of Primovist. And as we can see, the nodules are hypointensive, which is suggestive of adenomas. So we have a polyadenomatosis with one nodule having 6 per 6 centimeters in the segment 6, and we have a slight intrahepatic biliary dilatation. The lab work showed an elevated alkaline phosphatase and gamma GT. The tumor markers were negative, and the immunity study was also negative. So we have a patient that is asymptomatic. She stopped taking oral contraceptives 3 months ago, and we asked for a new MRI control after 3 months. This is the new MRI, 6 months after she stopped taking the oral contraceptives. And as we can see, there was no reduction in the dimension of the adenomas. Here we have the T2 phase. And the coronal view. I don't know if I can put. And here we have the MRI after the injection of the Primovist. We can also see that in the right lobe, we have another nodule with 4 centimeters that is more suggestive of nodular focal hyperplasia. In the right, we have the cholangial reconstruction. And so in summary, we have a young 36-year-old woman with excellent general status, asymptomatic, with polyadenomatosis, with the largest nodes having 6 centimeters in the right liver, and the nodules showed no reduction in size after 6 months of oral contraceptives. So the question we would like to ask you is, what would you do?
Shall we ask the specialist of this floor, Laurence?
I was sure. Okay. This is a typical case where very challenging about the management of such women. First of all, I'm not surprised that the oral contraceptive stopped just 6 months. It demands a lot of time to reduce after the stop of estroprogestative. So it's not surprising. The point is that when you have adenomatosis like that, it's important to classify the adenomatosis, and I think as I saw the MRI, it's inflammatory adenomatosis. So it's important to know what type of inflammatory adenomas. So my recommendation would be to biopsy one of these or two of those nodules. I think, but I have no time to see it very well, that all the nodules had the same pattern. Are there?
Except one. Yes.
Except one, but it was a nodular hyperplasia. And it's very frequent to have nodular focal hyperplasia mixed with adenomatosis. And I think that the liver is not quite normal, because there is enhancement in...
Micro. Ton micro, Laurence.
Yeah.
Sorry, we couldn't hear you.
We couldn't hear you.
Oh, sorry. So, from the beginning?
Just after the enhancement, the last portion, the last part of your...
Okay, so I wonder if there is not a vascular pathology in that liver, because the enhancement in the MRI was quite atypical. So we have to biopsy in order to know if there is a mutation of the beta-catenin, because you know that in inflammatory adenomas, some of them have beta-catenin mutation, and this is dangerous for the malignant transformation. Anyway, in that patient, you have an adenoma in segment 6, which is quite large, and the risk of bleeding is quite worrying. So my opinion is that, first of all, I would biopsy 1, 2, or 3 nodules to have analysis of the mutation of those adenomas, and then I would discuss the resection of the larger one, which is subcapsular, quite large, and so at this age, dangerous. During this operation, which should be done by laparoscopy or robotic surgery, Hugo, we could then biopsy other nodules to precisely know how to follow this patient and the rhythm of the follow-up.
So this is one first option. So Laurence, you would advocate first tumor liver biopsy and the normal liver biopsy before going to theater, before surgery. Any other comment, Hugo?
Yes, we were thinking about that, and we were thinking that, in fact, if you consider the largest lesion should be resected, would you prefer to opt for a resection of the largest one and biopsy the others intraoperatively? Or would you rather start with a simple biopsy with a percutaneous biopsy of all the nodules?
This is two options, in fact. I think that whatever the diagnosis of the mutation or not, the biggest nodule on segment 6 should be removed. So it's possible, two options are possible. The point is that but it's very, very rare, there is a mutation of beta-catenin in 2 or 3 nodules, we should think of other options than the resection. So the partial resection, I mean. So maybe you can go to theater to remove the biggest one and biopsy the other. It could be an option.
So maybe you're going to tell us what you did. Maybe you did a surgical biopsy and extended biopsy plus biopsy of the other lesions at the same time.
No, in fact, no. This is an open case. It's just from last week. We didn't do anything. We wanted to discuss this with you.
Okay. Any other proposal, comment? Because I personally probably will go to do a resection of the big lesion because I agree the 6 centimeter, there is a risk of bleeding, but at the same time, do biopsy of the other lesions and probably of the liver. That's one option. Pietro?
I would like Laurence to comment on thermal ablation, microwave, or embolization of some of the nodules.
Okay, that's always the question. In fact, in adenomatosis, there is a lot of lesions. So ablation of some of those lesions could be possible if there is a justification of that. So what nodule would you choose? In fact, the problem is that ablation is good when you want to prevent bleeding, for example. So it concerns large nodule, and large nodule are not easily ablated. So it's not, for me, it's not logical. If you want to prevent malignant transformation, it's a different point, of course. So I saw the MRI, and in the nodule of the segment 6, I saw nodule into the nodule, you know, and this is very important to have very good radiologists because now MRI is the key point. You have to analyze all the nodules, and this nodule of 6 centimeters is for me not quite exactly the same than the other, but maybe because it's bigger, but I think you should remove it, and this will allow a very good analysis of the whole nodule, which is not possible in a simple biopsy.
Yeah.
So for me, maybe it is the good option to resect completely this nodule to allow a good analysis of this nodule, biopsy small ones and middle-sized one, and then you will have a perfect analysis of this adenomatosis.
Yeah. Any other comment, Professor Bismuth?
No, I asked only Laurent. You will do it by laparoscopy?
Yes, definitely.
Okay.
Definitely. The segment 6 is very easy on laparoscopy. And on laparoscopy, for this young woman, I think laparoscopy or robotic surgery is the treatment of choice for this patient. And you can remove very large tumor with laparoscopy.
I would say, even Laurence, that I probably wouldn't use robotics here. I think it's too much, it's not needed for this operation. I would use laparoscopy also, yes.
And laparoscopic biopsy.
But okay.
Okay, I think we finished. Thank you. Thank you, Ines.
Thank you.
And thank you, Eduardo. I don't forget you, Eduardo. And of course,
Eduardo left already because of the children, the grandchildren had to leave.
Good. And thank you, of course, Gina. So today we finish the session. I remind you that our next staff meeting is the 24th of April, Saturday, always the last Saturday of the month. which will be the 24. Then we will let you know in 1 or 2 weeks, which is the exact date of the meeting of Varsovie. It could be a hybrid meeting. I think surely a part physical, but one part will be hybrid too. I hope that we may have the meeting, but we need to have a meeting. And for those who may come, I think it's good to come. Already, many of you answer that they will come, which is a good date to have the meeting and to meet once more between us. Okay? Thank you. I think we finished the session now, and I thank you, all of you, for your presence and your participation. Thank you, and prepare yourself for the next time, and be vaccinated. I'm vaccinated since 2 months now.
Yeah, we all are. And Laurence aussi.
Pietro, are you vaccinated?
Not yet. In Switzerland, doctors are vaccinated late, and I had the option of vaccinating myself in Milan, but I thought that I should leave the vaccine to some more needful Italians.
Okay, be vaccinated before you go to Varsovie, and we wait.
Yes, by the beginning of the summer, all Switzerland should be vaccinated. This is what they say.
And please make up your mind which the date of the meeting is the most convenient to you. I mean, whether the end of October or the beginning of November. It's important from the logistic point of view. Of course, we still have some time, but sooner better.
Honestly, I think you should decide, Christophe, and then we adapt. Decide it yourself and go ahead.
Okay. Oui. Let me ask a question to Laurence. Laurence
left. Laurence.
Yes.
Laurence is there.
Laurence, are you obliged to go to the American College this year?
On t'entend pas, Laurence. Micro.
Thank you, Gina. I always forgot. I'm not obliged, but I think I should go.
You should go.
Okay, so it means that we should approach towards November, but just please think it once again and let me know or let know Bismuth, and so we'll fix the date.
I will send a message to all the compagnons for the second date, and to answer for the 2 dates. Please answer, and then we will see with Christophe which date we choose very quickly. Okay, thank you, all of you.
Merci,
thank
au revoir.
Very much.
Au revoir. Thank you, everybody. Au revoir.
Monsieur Bismuth, mes salutations de Rome.
Au revoir.
Monsieur Bismuth, bonsoir, mes salutations de Rome.
Gennaro.
Gennaro, où es-tu, Gennaro? On ne te voit pas.
Je suis à Rome. Je suis à Rome. Je suis toute la session.
Non, mais je ne te voyais pas tout à l'heure. Et merci. Gennaro a envoyé à tous les compagnons des photos de la première année du meeting des compagnons. C'est extraordinaire. Nous avons maintenant, on va refaire toute l'histoire. Plus de 30 ans.
Oui,
Plus de 30 ans d'histoire.